Welcome back to the deep dive. So if you're anywhere near medical imaging or, advanced AI, you've definitely heard this question bouncing around. Will AI models, the really smart new ones, actually replace radiologists?
Yeah, it's a big one. High stakes.
Yeah,
And look, you see these press releases, right? Models hitting amazing scores on, well, pretty narrow visual tests. And the anxiety just spikes.
it really does.
So let's just get right to it. The short answer? No. Simple as that. AI is not replacing the radiologist.
Okay, no. But that feels too easy, right? If we just stop there, we're missing the really interesting part, the revolution that's actually happening.
Exactly. That no is just the starting line. Because the whole conversation, it needs to shift. It's not if AI takes the job.
Right,
It's how do we build a different workflow? A better one, maybe?
right.
Where, the AI does the heavy lifting, the repetitive stuff, the grind.
And the human clinician handles the judgment part. The context, the tricky bits, the patient care side of things.
Precisely. And that's our mission today in this deep dive.
Mm.
We're trying to move past the sort of theoretical fear
Mm-hmm.
and look at some real solid evidence. There's this fantastic recent study on knee x-rays, predictive modeling. It gives us a really concrete picture of what practice could look like with AI as, like, co-pilot.
So, finding the practical way forward, how to work with it, not, fight it.
That's the goal.
Okay, so let's dig into that core evidence then. This University Surrey research on knee osteoarthritis, you're saying it's a prime example of AI moving beyond just diagnosing what's there now.
Oh, absolutely. It fundamentally changes things.
Yeah.
What this system does, it's pretty amazing, actually. It takes a patient's current knee x-ray right now, and it doesn't just grade the arthritis.
Okay.
It generates a realistic picture, a visual forecast of what that same knee x-ray is probably going to look like 12 months down the line.
Wow. So it's not just, yep, you have arthritis. It's, okay, based on this, in a year, we expect the joint space to narrow like this. And it shows you.
Exactly like that. And on top of the picture, it gives an estimated risk score. Specifically, the chance the arthritis will get worse by a grade using the Kellgren-Lawrence grade, which is the standard doctors use.
That kind of visual prediction sounds incredibly complicated. How does it actually, draw the future knee without getting lost in all the technical acronyms?
Yeah, no, that's the core of the breakthrough. It uses something called a conditional diffusion model. Think of the tech behind those AI image generators like Deli or Midjourney, but fine-tuned for medicine.
Okay.
But instead of processing every single pixel, which takes ages, it's smarter. It first compresses the image data, focuses on the really important stuff like joint space, bone density patterns. This compression makes it fast and powerful.
Ah, so it learns the patterns of progression from lots of examples.
Thousands of them. And then, based on the current X-ray you feed it, it synthesizes the most probable future image. It's learned how knees tend to change over time.
And I guess the amount of data it learned from is key for it to be any good at predicting.
Oh, absolutely critical. This wasn't some tiny lab experiment. The model learned from, get this, over 47,000 knee x-rays.
47,000.
Yep, taken over time from almost 4,800 patients. It's from a big study called the Osteoarthritis Initiative Cohort. That sheer scale gives it what we call statistical endurance. It's seen more knees progress than any single human possibly could.
Right. No one person reads 47,000 longitudinal knee studies. And the speed increase you mentioned.
Massive. Clinically, its prediction accuracy was pretty solid. The AUC score was around 0.71, which is genuinely useful.
Yeah.
But for the day-to-day workflow, it runs about 9 times faster when making a prediction compared to older systems trying to do similar things.
9 times. Okay.
Yeah.
And importantly, it's not just a black box, right? It doesn't just give a score and say, trust me.
No, and that's vital for clinical adoption. For trust, it shows its work. It highlights 16 key anatomical points on the knee, basically showing why it's making that forecast.
So the clinician gets the risk score, the predicted image, and the landmarks the AI used.
Exactly. It supports their decision-making, doesn't just try to replace it.
Okay, so let me picture this. I'm the doctor. I get this report. It's not just patient has moderate OA. It's moderate OA, likely to progress to severe within 12 months. Here's what that looks like, and here's why we think so. Suddenly, my conversation with the patient changes completely. It's not just documenting. It's proactive. It's, okay, let's talk about aggressive physical therapy now, or maybe it's time for that orthopedic referral we discussed. It enables that longitudinal care, doesn't it?
That's the perfect way to put it. And it leads right into understanding why AI excels at certain things. That's statistical endurance. That's superhuman signal detection.
How does it achieve that? Is it just the volume of data?
It's volume plus technique. It uses things like radiomics and representation learning. fancy terms, but basically it means the AI can see and track thousands of tiny patterns, simultaneously subtle changes in bone texture, joint space narrowing, density shifts, things the human eye might miss or can't consistently track across, tens of thousands of images without fatigue.
So the machine wins on seeing the microscopic details at scale without getting tired. Superior signal detection. Okay, but let me play devil's advocate for a second. If the AI is objectively better at spotting those signals and forecasting progression, isn't there a danger that the human radiologist, by interpreting it, actually adds noise or inefficiency? What's the core human role that can't be touched?
That's the million-dollar question, isn't it? And the answer comes down to two things: context and agency. The model gives you an amazing statistical prediction, yes, but it has zero common sense, zero social understanding, and zero responsibility.
Okay.
Radiology isn't just pattern matching, it's applying clinical judgment to the pattern.
Can you give an example where that context just flips the script?
Sure. Think about that knee x-ray forecast showing high risk of rapid progression. Now imagine that forecast is for a fit 40-year-old marathon runner versus a 95-year-old in palliative care.
Right.
The image and the statistical risk might be identical, but the human response, the treatment plan, the urgency, the goals of care, they're totally different. The AI sees the bone density. The radiologist sees the patient's entire life situation.
Yeah, the AI can't weigh that knee finding against, say, a worrying discovery on a chest CT done the same day, or factor in the patient's diabetes or their fear of surgery. It doesn't sit down with the scared patient or their family and explain the options in a way they understand.
Exactly. That's the human's job, synthesizing everything: the scan data, the full medical history, the patient's own priorities and fears, their risk tolerance. The machine gives you the what arthritis is worsening and maybe the when, likely within 12 months. The human owns the so what and the what do we do now?
Okay, this makes sense. It leads us perfectly into the really practical bit.
Yeah.
Mapping out the tasks. Forget job replacement. Let's talk about task automation. What jobs does the AI do best? Let's make a list.
All right. The AI wins on tasks that are repetitive, data-heavy, and need speed or tireless consistency. Number one, triage and prioritization. An AI can scan incoming studies 24/7, instantly flag critical findings, think brain bleeds, collapsed lungs, and bump those cases right to the top of the human radiologist's work list. No fatigue, immediate alert.
That saves lives, potentially. Getting the expert eye on the critical case faster. What about during the actual interpretation?
Task number two, detection and segmentation. The AI does the first pass. It can highlight suspicious lung nodules, automatically measure organ size, outline fractures, mark subtle erosions on an arthritic joint.
So it speeds up the read and reduces the chance of missing something small, like a second pair of eyes.
Exactly. A safety net and an accelerator, but the human still signs off. And task number three, quantification and measurement.
Like in the knee study.
Precisely. Tracking tumor growth over multiple scans, measuring changes in joint space width. This used to be tedious manual work, prone to slight variations. AI gives you clean, consistent, automated measurements and trend lines over time. It quantifies the change objectively.
So triage, detection support, and quantification. The human then takes that output.
Right? The human takes that and does their irreplaceable tasks. First, setting clinical priority. Yes, the AI flags a bleed, but the human decides the overall priority based on the patient's symptoms, history, everything else going on.
Makes sense. What else?
Resolving ambiguity. What if the AI flags something but isn't sure? Or flags two possibilities? The human integrates clues from other scans, lab results. The clinical story uses judgment to make the final call.
Okay, and relating back to the measurements.
Critically, interpreting changes. The AI says a tumor grew 3 millimeters. Okay, great. The human decides if that 3 millimeter change is clinically significant given the patient's treatment, overall health, previous scans. Is it real progression, needing action, or just noise? That's a judgment call.
And the last one feels obvious but crucial.
Communication. Explaining complex findings, discussing uncertainty, managing patient expectations, building trust, answering questions. That's purely human.
So the job description is definitely shifting. Less pixel pushing, maybe, and more oversight, integration, communication.
Absolutely. The most valuable clinicians going forward will be expert supervisors of these AI tools. They'll know how to validate the output, spot when the AI is struggling, when it's out of distribution, and how to design workflows that safely combine the best of human and machine.
That term out of distribution feels important, like knowing when the AI sees something it wasn't trained for.
Exactly. You need the skills to interrogate the AI's confidence, to know its limits. It's a new kind of literacy.
Which brings us to the risks, the governance side. Even with a technically brilliant model like the Surrey one, there are big non-technical challenges.
Huge ones, and they all require human oversight. First, think about getting that data, 47,000 scans. That immediately brings up massive privacy and security issues.
Right. Protecting patient data, de-identification, secure storage. That's all human policy and process.
Absolutely. The algorithm doesn't care about HIPAA or GDPR. We do. Then there's algorithmic bias. Was the training data representative? Or did it skew towards a certain demographic or maybe one type of scanner? We need humans to constantly test for bias and retrain if needed.
That's critical for fairness. What about making sure it works everywhere?
That's generalization. Clinical reality is messy, as we said. Does the model trained at Hospital A work just as well at Hospital B with different machines, different patient populations? You need rigorous, real-world validation across diverse settings. Humans have to design and oversee that testing.
And you could have the best, fairest, most accurate model in the world, but if it's a pain to use.
Exactly. Workflow fit? Does it slot easily into the existing radiology software? Is the output clear? Can you act on it quickly? Does it surface uncertainty well? If using the AI adds 5 extra clicks or makes the report take longer, guess what?
It won't get used.
It won't get used. Doesn't matter how smart it is, the human factors of integration are paramount. And finally, accountability. The AI provides input, maybe even a draft report. But the clinical decision, the legal and ethical responsibility, that always rests with the human clinician.
Okay, so pulling all this together, the final verdict, the synthesis for everyone listening.
AI will replace specific, isolated tasks. The repetitive stuff, quantifying, helping triage, maybe doing a first-pass detection, things that don't need deep context or conversation.
But it's not replacing the radiologist. The person who integrates everything, handles the ambiguity, talks to the patient and the referring doctor, takes responsibility, and ultimately owns the outcome.
Precisely. The Surrey study is a perfect example. It forecasts progression, giving the human radiologist powerful new information to act on earlier, to communicate better, to focus on intervention. It makes the job more effective, arguably more humane.
So for people listening, maybe leaders in departments or just clinicians thinking about their own future, what are the concrete next steps? How do you actually manage this transition starting, like, tomorrow?
Okay, 3 practical things based on what we're seeing work. 1, run a small measurable pilot project. Don't try to boil the ocean. Use AI for a very specific task where success is easy to measure, like automated measurements, or maybe triaging one specific type of critical finding. See if it actually saves time or improves consistency in your setting.
Start small, measure results. Okay.
2, set clear acceptance criteria before you start. What does good enough look like? Track the performance, yes, but also track the workflow. How are people using it? Where are the handoffs? What actually makes the team faster or more confident? Scale only what demonstrably works for your patients and your team.
Makes sense. Adapt it to your reality.
Yeah.
And 3,
education. Institute something like an AI literacy hour. Seriously, get your team comfortable reading a model card that describes what an AI does and its limitations. Help them understand basic concepts like accuracy metrics, like ROC curves, and crucially, how to spot when a model might be unreliable, because it's seeing something unexpected, that out-of-distribution problem.
demystify the tech. Build confidence through understanding.
Exactly. You have to learn to work with the tools.
It's a powerful perspective. The machines offer speed, statistical insight, tireless detection. But that final connection, the understanding, the responsibility, that remains human. Remember what patients truly need when they come for a scan.
Yeah. They need someone to see them, not just the image, to explain what's happening, what the plan is, and to take responsibility for guiding their care.
AI will undoubtedly help us do that faster, more accurately, maybe catch things earlier. But it's the human element, the clinician owning that relationship and that judgment, that transforms the data into actual medicine.